Dr. Dr. Vizniak here, and we are going to talk about how to use clinic forms in practice. Before we get into more detail with this though, let's make sure we understand where are some other resources that you can use. Number one, most of this information comes from the Orthopedic Assessment Manual. In addition, any of the forms that I show you here are available to download on our website, as well as many more advanced forms to go over as well. How to use clinic forms. What is required for every patient visit? You need to review and discuss the initial patient intake form. You should also perform an initial scan exam or postural assessment and record your information on a SOAP note for the initial visit as well. Follow-up visits can just be done on a SOAP note. Peripheral and spinal joint exam forms can be used if you have specific exams that you would like to do, and a management plan must be filled out for every patient following the first visit. So let's go ahead and look at some of these forms, shall we? First form we see is the patient intake form, which talks about why are they receiving care, are they the right age, do they have consent, and then they go through and check any of these key issues that you might want to evaluate. It's in your interest if a patient says that they have a condition like edema or whatever else it is, they're putting check marks or X's, that you talk about it with the patient. So you can start your history there if you'd like. Next part, we go ahead and flip over some key information that you'll want to know as a physical medicine provider. Patient intake form, how long have they had this condition, basic questions you want to go through. Past health history is there, including things like orthotics, mattress age, last physical exam. Those are all key information you want to be aware of. List of any medications, why are they seeing a therapist or doctor at this time, and a consent form that says they understand the disclaimer and doctor-patient or therapist-patient confidentiality and what your goal is. So that's your informed consent. Written informed consent. We'll talk about a variation on that in a little bit. So you're going to take a patient history. This is our standard history form that we would use right here. Key thing, we're changing a few things here. It's no longer a chief complaint. No one wants to go to work all day and listen to complaints. It's a chief concern. And what are we doing as healthcare providers? We are trying to help patients with their concern. So please be clear on that. Chief concern is what we're working on. If you're looking at how this chart note is filled out, key things to note, there are a lot of abbreviations used. This will just save you time in practice. If you're asking a question and there was no response required, all you do is draw a circle with a line through it. So it shows you asked the question, but there was no significant finding associated. Conditional history is also there, and we have variations of this form as well on the website that you can download or in the textbook. So you finish your history and now you want to move on to the initial scan exam or postural assessment. History, inspection, palpation. This is your inspection palpation section of the exam. When we're looking here, you have a couple of notes. You can look at shoulder heights, head carriage, arches, all of that, and you can look at your start of your palpation. Palpation does not start and end here. The same thing with your history does not start and end here. New information is going to show itself, and you're going to ask new questions, and you might go back to your history form and write down some more information as it comes up. Also, when you're looking at your palpation summary, the 4 T's that you're looking for, you can find them here when the person's standing, but you're probably better off once the person lays down on the table to do further evaluation. You also want to make sure you perform functional tests, and those functional tests should be geared towards activities of daily living. Like the lumbar spine, a prime example, or lower extremity, the best functional test you can do is a simple squat and rise test. Other good functional tests involve shoulder checks or basic range of motion, but you can see how you would fill that out, and then your findings associated with it. So now your history, inspection, and palpation is done. You're going to go ahead and move on to, if required, a spinal joint exam that you can look at. So you can see active versus passive range of motion. So this joint exam is really your range of motion assessment, where you can look at muscle evaluation and create a differential diagnosis list. Your entire goal through this whole process is to create differential diagnoses of areas that you want to work on and focus on for that patient. So we'll say the spinal exam has been done, or the range of motion, history, inspection, motion. Maybe neuro is done if required. Maybe you have to do some muscle testing or special tests. Maybe you have to check neurovascular function. Depending on the specific case presentation, that's your prerogative. The next thing we run into is filling out a SOAP note. So if this SOAP note was for an initial visit on a patient, you would simply write C history form because you've already recorded it. If this was also an initial visit, you would write down C initial scan exam or postural assessment. If it wasn't, this SOAP has drawings of the skeleton on it where you could go ahead and add information. S is subjective, O is objective, A is action, and within the action, we see one of the key things that we have to do here is look for informed consent with our actions. And this is a big deal right here for people who aren't aware of this. This can save you litigation. This can make sure there's no miscommunication between you and patients. The biggest thing to realize is you will follow a PAR-Q procedure when you go through this. The PAR-Q procedure is, P stands for procedures. What would you like to do for treatment options for this patient? A stands for alternatives. What are some other things they could try should the patient not agree to your treatment? A stands for alternatives. You should give the patient options so they can make an informed decision and try other alternatives should they not agree with your treatment plan. R stands for risks, and the key things you have to say for risks include common and catastrophic outcomes. So that means if it's really common to have muscle soreness, tell them about it. That's a potential outcome. If it's rare, but it could happen that they could have, I don't know, say something like a stroke or something like that, then you need to make sure that they are informed of that potential outcome. The next thing is questions, and the key thing here is the questions are, does the patient have any questions? And this whole process has to be done at a language level that the patient can understand. If you're speaking to the general public who doesn't understand things like flexion, extension, abduction, adduction, you've got to make the language much more simple. If you're speaking to another healthcare provider, you can use your standard medical nomenclature. So there's our basic SOAP note right there. I would encourage everybody to fill out a verbal analog scale for pain and to describe whether or not the pain's getting better on a scale from 0 to 10, and also just remind yourself of contraindications for treatment for this person. Within the action, you're going to pick your modality, the technique used, the area of the body used it, and the results, and your reassessment method. So pre and post treatment, how did things change? And you want to make sure to set up treatment goals at this time. It's all about goals and measuring your outcomes. You can see a couple of variations here, heat, instrument-assisted techniques, and then you go into your future plan for this patient. Patient to return in how many days, recommended next visit, and then specific home care instructions you gave with frequency, intensity, and duration. So flexion of the low back, this was a patient with, as an example, patient with a tight low back. So every time they get out of their truck, we have them bend forward and stretch out their lumbar spine. And of course, if this is a legal document, you have to fill it out in pen and sign your name at the bottom. For these SOAP notes, again, there's lots of variations. This is when you're first learning how to fill out SOAP notes, you'd fill out something like this. As you become more advanced, you might go into a SOAP note that's more like this. And then eventually, SOAP notes that have more space for you to write, cover more visits on a single page. And again, all of these are available up on the website, as well as more advanced regional exam forms as well. I would strongly encourage you to go check those out. The last thing we come to is a management plan. And a management plan must be filled out for a new patient, and you talk about active problems and inactive problems, and phase of care, what you're involving, whether it's pain, stress, functional movement, decreased range of motion. And this is a big one here. Definitely take consideration to conditional factors. So what kind of conditional factors are out there? Well, disease and divorce behavior. If they're always in the same position, in the same action, or they're always eating the same crappy food, that's a disease-enforced behavior. Negative motivation. They're not happy with their job. Social or environmental. They can't get out of the position that they're in. Medical legal. That's a big one right here. In America, something called Greenback syndrome, and it's proven in the literature. If you look at patients who are going to look at a financial settlement, their condition winds up lasting longer, and the symptoms are more severe compared to people who realize there is no financial gain at the end of this. Home instructions, you want to make sure that that's written down, so stretching, heat, rest, however long you told them to put it on for, work restrictions if indicated, and then treatment modalities that you actually used. You also want to come up with a plan for treatment frequency, and then eventually progressing through treatment goals and outcome markers to measure those goals. Let the patient know, and you should work together on this. What am I doing to help you solve the problems, and how are we going to tell that the problems are getting better, or maybe they're not? How are we going to tell that they're getting worse, and we might have to modify our treatment? So hopefully this is helpful for you as a student looking at this, or as a practitioner deciding how you want to fill out your chart forms. Again, on our website and also inside of our textbooks, there are multiple forms that you can go ahead and look at and download and decide what you want to do, and actually put in conjunction with your electronic medical records should you decide to go that route as well. I'm actually a big fan of electronic medical records, but they often leave areas for improvement. Like one prime example I'll give, just really quick here, is if I'm filling out a SOAP note, what do I like to do in my SOAP notes? So if we're looking at a SOAP note for a patient file for me, I'll actually write information down about birthdays or kids or other information like that. So the next time the patient comes in, I can have something to talk about with that patient and we can have a better connection. Patients love it when you do things like that. And it's just something that can separate you from the average practitioner to a super practitioner. Hopefully this has been educational for you. If you have any questions or comments, please leave them below. And I thank you very much for your time and hope that you have a great day.